Same? Okay. Welcome back, guys. Okay, let me reduce the volume. Yeah. Okay, welcome back, guys. Now this is our second class on pathology series. Okay, in yesterday class already we have started with the cell injury. Also we have discussed about the basics about the cell injury. Okay, different types of cell death, that is reversible cell injury, irreversible cell injury. Okay, we have seen. Also we have discussed about the necrosis and apoptosis. Okay, so different types of necrosis, apoptosis, the intrinsic pathway, extrinsic pathway. Okay, all the important points we have seen. And now in this class, let's continue with the next remaining topics in the cell injury. Okay, if you have any doubts, you can all the time ask me on the live chat. Let me open the live chat. Meena, salam dear, I really fall in love with the way you guys are teaching. Thank you from USA. I appreciate that. Yeah, at the end we are here. Okay, just a little late because there are heavy rains going on here, so a little traffic jam. Anyway, now let's continue. Okay, let's continue. In yesterday's class we have completed till apoptosis, right? Necrosis and apoptosis are completed. Now let's do other types of cell death. Okay, the other types of cell death. Now the other types of cell death are, see, necroptosis. Necroptosis, sir. The questions which were asked in the exam. These are the topics which were very important. Necroptosis. See, necroptosis, what exactly is it? Is it apoptosis or is it necrosis? See, necroptosis is a combination of both. Okay, it's a combination of both necrosis as well as apoptosis. Okay, just let me open the chart session. So if you have any doubts, yeah. Okay, so necroptosis, what exactly is it? Necroptosis is both a combination of necrosis and apoptosis, sir. So something related to necrosis and something related to apoptosis happens here in the necroptosis. Okay, now so this is also called as programmed necrosis. It's mainly a necrosis. Okay, it's mainly necrosis. Why we are calling it as necrosis? At the end you will understand. Okay, at the end you will understand. So necroptosis is also called as a programmed necrosis. In the name itself it's there. Necro stands for necrosis. And tosis, what is this? Apoptosis, sir. So necrosis and apoptosis. Now this necroptosis, yes, it is caspase independent cell death. Why we are not calling it as apoptosis, complete apoptosis? Why? Because the caspases, no caspases are involved. Cell death is happening. But yes, it is programmed, but the caspases are not involved. In yesterday's class we have discussed caspase number 8, 9, 10, 3, 6, 7 caspases. Okay, those caspases are not involved in necroptosis. Okay, now is it an active process, sir? Yes, of course it's an active process, just like apoptosis. Okay, apoptosis is active, so necroptosis is also active. Next, is it physiological or pathological? It's both physiological and pathological, just like apoptosis. Apoptosis is physiological and pathological. Here also this necroptosis is again physiological and pathological. Just recap what are the important things which you should know. Necroptosis is also a type of cell death. Just like necrosis and apoptosis, necroptosis is also a special type of cell death. Sir, is it necrosis or apoptosis? Sir, it's combination of both necrosis as well as apoptosis. Certain features of necrosis are seen and certain features of apoptosis are seen. Okay, why we are calling it as apoptosis? What is something related to apoptosis here? It is programmed. Okay, it's a programmed cell death. Okay, it's an active process, yes, true, and it is also physiological as well as pathological, both. Now, as we are saying it, this is both physiological. Necroptosis is seen both in physiological conditions as well as pathological conditions. Now let's see, what are the physiological examples of necroptosis? Physiologically, necroptosis happens in our body. Do you know where? Sir, the growth plate formation. For your exams is very important. Okay, we are again and again I am reminding, we are all the doctors, sir. Okay, we are not going to be like you guys are not going to be pathologists. You are going to be doctors. So you should know necroptosis is physiological and pathological. What are the physiological examples and what are the pathological examples? Mainly concentrate on them. Okay, for your exams. Okay. So they are going to be both physiological and pathological. Physiological example is during the growth plate formation. Okay, during the growth plate formation in your bones, certain cells will undergo necroptosis. It is physiologically. Okay, it is physiological. And what are the pathological examples of necroptosis? Where you will see pathological necroptosis? In pancreatitis condition, in fatty liver means steatosis, you know it, right? Steatohepatitis, the fatty liver. Whenever the person is suffering with fatty liver, that's definitely pathology. Pancreatitis, definitely pathology. Okay, and cytomegaloviral infection, CMV. If this virus enters into our cell, if this virus enters into a cell, that particular cell will undergo necroptosis. It will commit necroptosis. Okay, and neurodegenerative disorders like Parkinsonism and Alzheimer's. Okay, in these conditions, in Parkinsonism and in Alzheimer's, the neurons. Okay, Parkinsonism is pathological. Alzheimer's is pathological. So in these conditions, neurons will undergo necroptosis. Okay, so now tell me, necroptosis, important points. It's both physiological as well as pathological. It's a combination of necrosis as well as apoptosis. Why I am saying this as necrosis and apoptosis, later you will understand. We will understand. Okay, but tell me, what are the physiological examples of necroptosis? Growth plate formation, mammalian growth plate formation. And what are the pathological examples? In pancreatitis, in yesterday's class, I have discussed in pancreatitis, acute pancreatitis, there is liquefactive necrosis. Peripancreatic fat will undergo fat necrosis, okay. But some of the cells in pancreatitis will undergo necroptosis also. Okay, necroptosis. So fatty liver and neurodegenerative disorders like Parkinsonism and viral infections like cytomegalovirus infections. So in these conditions, a special type of cell death will occur, and that special cell death is necroptosis. Okay, now what is a pathway? I have said you, it's a programmed cell death, program. Okay, it's not happening just like that. Okay, haphazardly. There is a sequence of events are going to happen. Okay, see, the pathway of necroptosis is, dekho. Now, first, tumor necrosis factor. The tumor necrosis factor is going to come and act on the cell. Okay, for example, imagine this is the cell that's going to undergo the necroptosis. Now, first the tumor necrosis factor alpha is going to come and bind with this cell. First, it will go and come and act on this cell. So, the tumor necrosis factor, I will show in the image also. So, this is the tumor necrosis factor. Dekho. It is going to bind with its receptor, tumor necrosis factor receptor. Okay, tumor necrosis factor is coming and binding with the tumor necrosis factor receptor. So what happens? Now this tumor necrosis factor receptor, it's going to activate certain proteins inside the cell, certain enzymes I should say, certain enzymes inside the cell called as the RIP kinases. So TNF is going to bind with its receptor. Binding of this activation of this TNF receptor is going to activate the RIP kinases. Okay. So now this RIP kinases, there are two types of RIP kinases, RIP kinase 1 and 2. There are two RIP kinases. This RIP kinases, what they will do? Now they will activate something called as MLKL or MILK-L. I used to remember, like no need to remember the full forms. Okay, MLKL. Okay, RIP kinases are going to activate which structure inside the cell? MLKL. That RIP kinase, RIP kinase. Kinases, what they will do? Kinases will do the phosphorylation, right? So these RIP kinases are going to do the phosphorylation of this MLKL. So once the MLKL is phosphorylated, once it is activated, that's it, sir. Now it is going to cause the cell membrane damage, and now the cell membrane will be damaged. The cell, water will enter into the cell will become swollen. Okay, so cell membrane damage is occurring, inflammation will occur, cell will swell, and it will die. It will die. So there is a pathway, sir. There is a pathway. Okay, there is a programmed, there is a blueprint. This is how it should happen. So that's why we are calling it as apoptosis. Okay, that's why we are calling it as apoptosis. Okay, then why it is called as a necrosis? See, at the end of the day, the cell membrane damage is happening. Normally in apoptosis, cell shrinkage will happen. The cell membrane is not going to be damaged. But here in necroptosis, at the end result, sir, morphologically, the cell is getting damaged, and this damage looks like necrosis. Okay. After the cell damage, even inflammation will start, sir, because the cell membrane is getting damaged. The cellular contents will leak out. Once the cellular contents are leaking out, that will trigger the inflammation. That will recruit the neutrophils. Inflammation will start, sir. Okay. So, once look at here. Sir, this is the cell. Okay, imagine now this is the cell membrane. Now on the cell membrane, who is there? TNF receptor. This is the tumor necrosis factor receptor. When the tumor necrosis factor binds with the TNF receptor, Now what it will do, I said you, it's going to activate the RIP kinases, RIP kinase 1 and RIP kinase 3. Now what this RIP kinases will do? Sir, this RIP kinases are going to phosphorylate MLKL. Okay. So now what this MLKL will do? Now it will cause the cell membrane damage and lead to death of the cell. Okay. So necrosis, like at the end of the day, the morphologically the cell death looks like necrosis, because after the cell death inflammation will follow up, so looking like necrosis, right? Okay, done, sir. Even here this is a little more detailed diagram of necroptosis. What exactly happens? Same events. See, TNF is going to bind with its receptor, tumor necrosis factor receptor. Now when the tumor necrosis factor receptor is activated, देखो what is happening? The RIP kinase 1, 3, these RIP kinases are activated. These RIP kinases, what they will do? Sir, these RIP kinases, of course, here one point I want you to know. Here caspase is involved. Which caspase? Not active caspase, inactive caspase. Okay, inactive caspase number 8 or the pro-caspase 8 is involved here. Okay, now you can ask me, sir, you said this is caspase independent cell death. Dekho, necroptosis. Sir, you said that it is caspase independent. Yes, caspase independent only. But here see, dekho, it's an inactive caspase 8. Okay, not active caspase. This is pro-caspase. Okay, pro-caspase 8 is involved. Pro-caspase 8 is involved. So now what happens? Sir, these three things, RIP kinase 1, RIP kinase 2 along with this pro-caspase, they will cause phosphorylation. Dekho, phosphorylation of MLKL. Once the MLKL is activated, what happens? That will cause necroptosis. Done? So the mechanism also I have explained you. Now in your exam, what they will ask you is RIP kinases are involved in. RIP kinase 1, RIP kinase 3, MLKL, they are all involved in the necroptosis pathway. Okay, initiation is from the tumor necrosis factor. Tumor necrosis factor activates the tumor necrosis factor receptor, and all the events you already know it. So after necroptosis, inflammation is seen. Yes, cell damage, cellular swelling, cell damage followed by inflammation. Inflammation will be seen, sir. MCQ. Okay. This is MCQ. Inflammation is seen in necroptosis. True. Okay. Is everything okay? Guys, is everything okay? Shall I continue? Shall we continue, guys? Is everything okay? Done. Next, continue with the pyroptosis. Necroptosis completed. Next one is what? Pyroptosis. So what exactly is this type of cell death? This is also a type of cell death, necrosis, apoptosis. The next type of cell death that I am going to discuss is called as a pyroptosis. In this pyroptosis, as a doctor going for the exams, what you should remember is, dekho, pyro here stands for a pyrogen. Okay, pyrogen. What is a pyrogen? The pyrogen is a chemical which is going to cause a fever. Okay, so after this cell death, in this type of cell death, or I should say, after this cell death, the person is going to experience the fever, sir. Okay, so pyro means it's a, like, the agent which gives the fever, the one which causes the fever. Okay, so what is that pyrogen in this case here? The pyrogen in this case is interleukin 1. Okay, interleukin 1 is going to be released, and so pyroptosis, pyro completed, and again see, ptosis is there. What is the ptosis? Apoptosis. Okay, so pyroptosis is a combination of pyrogen and apoptosis, pyroptosis. So why I am using the word apoptosis here? The reason why I am using the word apoptosis is because again this is programmed cell death. Okay, this is programmed cell death, sir. So you can see a sequence of events. Okay, sequence of events are going to occur here. Okay, shall we begin? Same. Now this pyroptosis, listen here. See, there is an antigen. Now antigen might be bacteria, Salmonella, Shigella bacteria. Okay, it was actually discovered with those organisms. So antigen, let's take a bacteria. Okay, the bacterial antigens. Okay. Now this bacterial antigen is going to come and bind with this receptor on the cell. Who recognizes these antigens? Toll-like receptor. TLR stands for toll-like receptor. Okay, so this bacterial antigen, it's going to bind with the toll-like receptors. Now these toll-like receptors are activated, sir. First toll-like receptors are activated. Okay, now these toll-like receptors, what they will do? Now, once if you activate them, they are going to convert the procaspase 11, 4 and 5. Mainly here important is the 11, procaspase 11. Okay, procaspase number 11, 4 and 5 will be converted into active caspases. Active caspase number 11, 4 and 5. Now, you should look here. See, caspases are getting involved or not? Yes sir, caspases are getting involved. Then why we are not calling it as just like apoptosis? Why this is not just apoptosis? Why it is called as pyroptosis? Because yes, of course this is apoptosis, but the caspases which are involved here in this pyroptosis are different. These are the different caspases. In apoptosis, in the intrinsic pathway and in extrinsic pathway, in yesterday's class I have discussed. In apoptosis, which caspases are involved in apoptosis? Sir, caspase number 3, 6, 7 and even the caspase number, the initiator caspases like the caspase number 8, 9, 10, they are involved. But here look at the caspases. These are caspase number 11, 4, 5. These are different caspases which are getting involved. Excellent fun mode. Yes. Okay. Next. Screen is blurred. Okay, that's internet issue on your side. The screen is like, from our side everything is clear. From our side everything is clear. Okay, so now just tell me what is happening in this pyroptosis. In this pyroptosis, it's an actually combination of both apoptosis as well as in this pyroptosis actually it is a pyrogen involved. Here there is a pyrogen involved, sir. What is that pyrogen? I will discuss. Okay, and what's happening? Antigen binds with toll-like receptor. So the procaspases are going to be converted into active caspases. Now, dekho, sir, now once these caspases are active, now they are going to activate something called as GSDMD. Sir, do you know what is this GSDMD? So this GSDMD for gasdermin. Okay, something called as gasdermin is getting activated. Now, what is this gasdermin, sir? I will explain you. Okay, I will explain you. In this diagram, I will explain you. But for now, look at here. Caspase number 11, caspase number 4 and caspase number 5 are activated. Now they are going to activate or they are going to produce this something called as gasdermin. Now this gasdermin, do you know what it will do? Sir, now it is going to cause the cell membrane damage. Actually, it will put pores, sir. It will put pores. Okay, this gasdermin, it is going to put holes into the cell membrane, causing the cell membrane damage. First, cell will start to swell. Cell membrane damage will occur, followed by inflammation. Again, say inflammation is going to be there. Okay, cellular swelling will occur, cell membrane damage and inflammation. So, even it is looking like necrosis, right? Yes, even this type of cell death, inflammation will be there. Okay, even in this type of cell death, inflammation will be there, sir. Okay, so this GSDMD is going to be produced. Just tell me, sir, bacterial antigens are going to bind with the toll-like receptors. The toll-like receptors are going to be, once they are activated, they will convert the procaspase number 11 into active caspase number 11. Caspase number 11 is most important. Now this caspase number 11 is going to activate the gasdermin. Gasdermin, what it will do? It is the one which causes the cell membrane damage. So this is one half of the story. One half of the story. Sometimes, do you know what happens? Sometimes the antigens can directly enter into the cell. The bacterial antigens can directly enter into the cell. Once they directly enter into the cell, now they are going to bind with node-like receptors. Okay, now they are node-like receptors, sir. Okay, now they are binding with node-like receptors. Antigen binding with node-like receptors. See, after the class, the entire yesterday's class and today's class PDF will be shared in the group. Okay, yesterday's class and today's class PDF will be shared with you. Okay, in the Telegram channel, in one single PDF, entire cell injury chapter will be shared. Okay, so antigen is going to bind with the node-like receptors. Now this complex is going to activate something called as inflammasome. Okay, so inflammasome is activated in pyroptosis. This inflammasome is activated, sir. I will show you in the image also. Okay, so inflammasomes are activated. Now, what happens? What this inflammasome will do? Sir, this inflammasome, dekho, it will activate procaspase number 1. Okay, procaspase number 1. This is the most important, sir. On this side, procaspase number 11 is important. On this side, procaspase number 1 is important. So this procaspase number 1, these are the enzymes, these are the very dangerous enzymes, caspases. They will cause the death of the cell. The procaspase number 1 is converted into caspase number 1. Now this caspase number 1, what it is doing? So now this caspase number 1 is again going to produce gas germin. Again going to activate the gas germin. So you know it. Once the gas germin is produced, it is going to put the holes inside the cell membrane damage, cell death. Okay. And not only that, so this caspase number 1 is going to activate pro-interleukin 1 into interleukin 1. Okay. What I am telling you, this caspase number 1, sir, what it will do? It will convert the pro-interleukin 1, means inactive one, okay, inactive pro-interleukin 1 into active interleukin 1 and interleukin 18. So caspase number 1, it is going to help in production of which interleukins? Interleukin 1 and interleukin 18. In this pyroptosis, now tell me, there are two pathways, sir. There are two pathways by which the gas germin can be produced. What are the two pathways? One thing is, when antigen binds with, when antigen binds with toll-like receptors, the toll-like receptors are going to convert the procaspase number 1145 into active caspase number 1145. These active caspases are going to activate the gas germin. Gas germin is going to cause the cell damage. Done. Not only that, if a bacterial antigen, if it enters into the cell, now these antigens can be recognized by the nod-like receptors. Now, antigens are going to bind with the nod-like receptors. Now, they will activate a structure called as inflammasome. Now, the inflammasome, once it is activated, they will convert the procaspase number 1 into active caspase number 1. The caspase number 1 again is going to produce the gas germin. Gas germin do the cell death. Point number 1 is the caspase number 1 is going to help in production of which interleukins? Interleukin 1 and interleukin 18. So this is the point. This interleukin 1, it comes out of the cell. This interleukin 1 is the one which causes the fever. So this is the pyrogen. Interleukin 1 is called as a pyrogen. So pyrogens are produced at the end. That will cause the fever, sir. Okay. So what else you should know? Please look here. Sir, this caspase 11, okay, important one, the caspase 11, 4-5. Okay, this caspase 11 mainly. So what it is doing? It is also directly activating the inflammasome. Okay. So it is also activating what? Inflammasome. Okay. So inflammasome is activated by this nod-like receptors, antigen nod-like receptors, as well as this caspase number 11 can also activate the inflammasome. Now, whatever we have seen, let's look at in the pathway. Okay, this is simple diagram which I have drawn. Now, let's look the pathway, sir. Let's look at this pathway. Okay. Now, look at here. See, now this is the bacterial antigen, lipopolysaccharides, bacterial antigen, sir. Now, this bacterial antigen, where is going to bind with? It is going to bind with toll-like receptor. Once the toll-like receptors are activated, now tell me what they will do. They will convert the procaspase number 4, procaspase number 5 and procaspase number 11 into active caspase number 4, 5 and 11. So these caspases are produced, the active caspases are produced. Now what these caspases will do? I have explained. Sir, these caspases, they will produce this gas germin. Sir, what this gas germin will do? Sir, this gas germin, see, gas germin pore formation, it's going to form the pores in the cell membrane damage. The fluid will come into the cell. Fluid will, cellular swelling will occur, cell damage will occur. Okay, cell membrane damage and cell death will occur, sir, followed by the cell death. Okay, so this is one half. And not only that, you can also see here, see these antigens, they can directly enter into the cell. Okay, these antigens, they can directly enter into the cell. Now, after entering into the cell, they bind with nod-like receptors. Now, once they bind with nod-like receptors, they will activate what? They will activate inflammasome. These inflammasomes, what I have said you, they will convert procaspase number 1 to active caspase number 1. Now what this active caspase number 1 will do? Dekho, this active caspase number 1, say again, it is activating the gas germin. Now gas germin, what it will do? It will put holes in the cell membrane, kills the cell. Okay, and not only that, this caspase number 1, what it is doing? It is converting the pro-interleukin 1 and pro-interleukin 18. Pro means inactive. So this caspase number 1 is converting the pro-interleukin 1 and interleukin 18 into active interleukins. See, interleukin 1 and interleukin 18 is released out of the cell. They are coming out of the cell and they are responsible for the fever. Interleukin 1 is responsible for the fever mainly. Okay, so with this, pyroptosis is also completed. Apoptosis completed, pyroptosis is also completed. I have said you, this caspase number 11, see, they can directly activate the inflammasome. This is called a secondary inflammasome activation. Okay, so this caspase number 11 can directly activate the inflammasome. I have shown here. Okay, see, caspase number 11, it can directly activate the inflammasome. I have shown you. Okay, with this, necrosis, apoptosis, necroptosis and pyroptosis all are completed. Okay, is it clear guys for you? Is it clear? Both type of cell deaths? Okay. I'm having little cold because of the environment. So, we have seen the 4 important types of cell death: necrosis, apoptosis, necroptosis, pyroptosis. Most of the students, majority of the students, they know necrosis, apoptosis. But you should know, you are a special student, so you should know that what is necroptosis and what is pyroptosis. Okay, what are the pathways? MLKL is activated in necroptosis. RIP kinases are activated in necroptosis. Caspase number 11, caspase number 1 are activated in pyroptosis. Interleukin 1 is produced in pyroptosis. Fever is seen in pyroptosis. Okay. Now, after this, the next topic that we are going to start is cellular adaptations. Very simple topic. In 15 minutes we can complete this. 15-20 minutes maximum we can complete the cellular adaptations. Okay. But very high yielding for the exam. Very high yielding for the exam. Now, let me ask you, what exactly is this cellular adaptation? What exactly is cellular adaptation, sir? See, when you are stressing a cell, when you are giving stress to the cell will try to adapt to that stress. Okay, if I am giving you more and more work, so initially you will try to adapt to the environment. So even cells will try to adapt to the stress. So this is called a cellular adaptation. Okay. So for example, simple example I will give you. If you are going and doing exercise every day, you are putting stress on your muscles, right? You are putting stress on your muscles. What happened to your muscle? In order to encounter that stress, in order to weigh the, to have the power to lift the weights, now your muscle cell will undergo hypertrophy. Your muscle cells are becoming bigger so that they can help you in the work. Okay, adaptation. The cells are getting adapted to the stress. So, how many types of cell adaptations are there, sir? Sir, cell adaptations include hypertrophy, hyperplasia, metaplasia, atrophy. Okay, we'll discuss about them one by one. Okay, first type of cellular adaptation is hypertrophy, sir. Hypertrophy kya hai? What exactly is this hypertrophy? Now imagine there is this one cell. Okay, normally this is the size of the cell. Now if this cell, if it increases in the size, if it becomes this much big, okay, if it becomes this much big, so now what have happened? Hyperplasia or hypertrophy? Hypertrophy, sir. So hypertrophy means increase in the size of the cell. Okay, the size of the cell is increased. Okay, the size of the cell is increased. So increase in cell size. Why cell size is getting increased? Now what is the reason? What is the primary reason why the cell size is getting increased? Because in that cell, when you are giving stress, in that cell, protein synthesis is increased in the amount of protein synthesis increased. That's why the cell is increasing in size. Okay. Next, now exam point of view, what you should know, that when hypertrophy is happening, the proteins are getting more and more, right? More and more protein synthesis is happening. So the cell size is also increasing. The proteins are helping in the formation of the cytoskeleton. So the cell size is increasing. Now in the cells, what you will find, what you will observe, sir, in the cells, the transcriptional factors, okay, transcriptional factors are increased. Now what are transcriptional factors? Transcriptional factors are the ones which helps in the protein production. So these transcriptional factors, okay, so transcriptional factors, they will cause first transcription followed by translation, proteins will be produced. Okay, you know it, right? From the DNA, first transcription occur followed by translation. At the end of the day, DNA is going to be produced. So in this cell, in that particular cell which is undergoing hypertrophy, if you check, the transcriptional factor levels are more. Which transcriptional factors, sir? These transcriptional factors are called as GATA4, NFAT and MEF2. See, these are the transcriptional factors which are increased in the cells. Okay, in those cells which are undergoing hypertrophy, these transcriptional factors are increased, elevated. Their is elevated, sir. Okay, is that clear? Now, after this, let's discuss about the examples. Okay, where you will see the hypertrophy, sir. In which conditions you will see the hypertrophy? Dekho, sir, when you do go for the exercise, okay, when you go for the exercise, Varun Kashyap, what is the connectivity? Do you have any issue with the internet? Buffering too much? Maybe it's your internet that's like, you know, not good. Okay, now from our side everything is good, sir. Next, so exercise, dekho, exercise, whenever you do exercise, what happened to the muscles? Muscles will undergo hypertrophy, right? Okay, muscles will undergo hypertrophy. Whenever you do exercise, muscles will undergo hypertrophy. That's one example. Next, outflow tract obstruction. So what is this outflow tract obstruction? So in the cases of outflow tract obstruction, again the organ will undergo hypertrophy. One example I will give you. Look here. Now imagine this is your left ventricle. I am drawing here the left ventricle, only the left ventricle. Now this is the outflow from the left ventricle. What is this? This is the aorta. Now imagine this is the left ventricle, this is the aorta. Now what is this valve which is present over here? The valve is the aortic valve. Now in this condition, imagine the aortic valve is stenosed. Okay, the aortic valve is stenosed, that is aortic stenosis. The patient is now having aortic stenosis. When the patient is having aortic stenosis, in order to push the blood into the aorta, okay, now this left ventricle have to push the blood into the aorta, right? So what happened to the left ventricular size? So now this left ventricular myocytes, they will undergo hypertrophy. So now you are going to have a very big heart, sir, very big heart, big size heart. The hypertrophied heart is going to be seen. Okay, so whenever there is an obstruction, the proximal part will undergo hypertrophy. Okay, now this is one example. And apart from that, especially for your exams, especially for the board exams, FMJ exam, NEET exams, these questions will be asked. Sir, breast hai na? Breast tissue hai. Sir, breast is going to increase in size. The breast tissue is going to increase in size. In which condition? During puberty it will increase. During pregnancy it will increase. Now, why the breast tissue, the breast size is increasing? Is it because of hypertrophy or hyperplasia? Yes, both because of hypertrophy, hyperplasia. So during puberty and during pregnancy, in both the conditions, both the hyperplasia and hypertrophy will occur. Both will occur. But hyperplasia is more prominent than the hypertrophy. Hyperplasia is more, sir, more prominent than the hypertrophy. Okay. Same way uterus also. Uterus. Sir, uterus during puberty and during pregnancy, it will increase in the size. The uterine size will increase. Okay, the uterus size will be increased. Why there is this increase in the size? Why, sir? This increase in the size is again because of both hypertrophy as well as hyperplasia. Both hypertrophy occurs as well as hyperplasia occurs. But hypertrophy is the best answer. These are the already asked questions. Okay, in breast, hyperplasia. Breast mein hyperplasia is more than hypertrophy. And in uterus, the hypertrophy is more than the hypoplasia. Okay. So, what are the 4 examples of the hypertrophy I have given? Exercising muscles, outflow tract obstruction, breast during pregnancy and puberty, and uterus during pregnancy and puberty. In breast there is more hypoplasia, and in uterus there is more hypertrophy. Okay, more hypertrophy than hypoplasia. And tell me, hypertrophy means what? Increase in the cell size. Because of what? Because of the increase in the transcription, because of the increase in the protein synthesis by the transcription factors. Which transcription factors are going to be elevated? The transcription factors are here, the GATA4, NFAT and MF2. Now after this, let's discuss about the next cellular adaptation. Cellular adaptation, sir. Okay, that is hyperplasia. The next cellular adaptation which we are going to discuss here is a hyperplasia, sir. So what exactly is hyperplasia? Hyperplasia means one cell, it is dividing into many cells. Okay, the number of cells, one cell will divide into 2, 2 will divide into 4, 4 will divide into 8 cells. Okay, so what is hyperplasia? Hyperplasia means increase in the number of the cells. One cell dividing into 2 cells, these 2 cells dividing into 4 cells. Means due to the mitosis, the number of cells are getting increased. So increase in cell number. Okay. Now here regarding hyperplasia, I want to ask you some questions. Sir, is this hyperplasia, is it dangerous? Is it going to cause cancer? Increase in the more number of cells. Cancer is also the same thing, right? More and more and more and more divisions, more and more divisions. So here, is this hyperplasia, does it increases the risk of cancer? Yes, of course. Certain types of hyperplasias increase the risk of cancer. What is the example? See, especially in the postmenopausal females, they will get a tumor, sir. They will get a tumor in their ovaries, ovarian tumor. They will get this ovarian tumor. So what is the name of this ovarian tumor? This ovarian tumor is called as a granulosa cell tumor. See, granulosa cells, you know, granulosa cells are the cells which produce the estrogens in the females. Granulosa cells. So these granulosa cells, they are producing excessive amount of the estrogens. Because of the presence of excessive high levels of estrogens, now what happens? Now endometrium will start to grow much more and more. So more and more endometrium is growing. That is nothing but endometrial hyperplasia. Okay, so in this tumor condition, granulosa cell tumor condition, more estrogens are there. So these estrogens, they can lead to endometrial hyperplasia. So this endometrial hyperplasia, now in postmenopausal females, now she is at a risk of developing endometrial cancer. So this endometrial hyperplasia, it may turn into, not every time, it may turn into endometrial cancer. Okay, endometrial cancer, sir. Okay, so endometrial cancer. Even the topic of endometrial cancer, I have explained this. Okay, so you can find the endometrial cancer video on the YouTube in the SARS channel. There I have explained endometrial hyperplasia can increase the risk of endometrial cancer. Next, let's discuss about other type of hyperplasia, sir. In males, there is something called as benign prostatic hyperplasia. Benign prostatic hyperplasia. In the name itself, it's there. Dekho, benign hai, benign condition. This BPH, benign prostatic hyperplasia, it does not increase the risk of cancer. Usually hyperplasias can increase the risk of cancer, true. But which hyperplasia do not possess the risk of cancer? Benign prostatic hyperplasia. Okay. Now something related to pharmacology which you should know is, sir, for the endometrium, what is the food? What is the stimulus for the endometrium? It's the estrogens. It's the estrogens. So granulosa cell tumors are producing more and more estrogens. That estrogen is stimulating the endometrium to grow much more. In males, the prostate. For the prostate, what is the food, sir? What is the stimulus for the prostate to grow? It's not the testosterone. Dekho, testosterone in males, it will be converted into 5-dihydrotestosterone. Okay, the DHT, sir, 5-dihydrotestosterone. Okay, so the testosterone is getting converted into dihydrotestosterone. Just 1 minute, let me take a tissue. Okay, testosterone will be converted into dihydrotestosterone with the help of enzyme 5-alpha reductase. With the help of this 5-alpha reductase, testosterone is getting converted into dihydrotestosterone. This dihydrotestosterone will stimulate the prostate to grow. Okay, dihydrotestosterone is the one which stimulates the prostate to grow, leading to benign prostatic hyperplasia. Now, how to treat this condition? Which drugs are used in benign prostatic hyperplasia? I have taught you. That is the dihydrotestosterone, which is the stimulus for the prostate to grow. So we can inhibit this enzyme 5-alpha reductase. Let's inhibit the 5-alpha reductase. So dihydrotestosterone levels will decrease. So who are the 5-alpha reductase inhibitors? Finasteride and dutasteride. Okay, so these drugs, finasteride and dutasteride, these are the 5-alpha reductase inhibitors. So they will decrease the dihydrotestosterone levels. When the dihydrotestosterone level decreases, benign prostatic hyperplasia will be controlled. Okay, will be controlled, sir. The rate of growth will be controlled. So now tell me important points about the hyperplasia. Sir, hyperplasia is increase in the number of cells. Hyperplasia, it's a precancerous condition. Yes, it increases the risk of cancer. Now, example of hyperplasia is endometrial hyperplasia, okay, which is seen in postmenopausal females because of granulosa cell tumor. Now, it increases the risk of cancer, true. And in males, there is something called as a benign prostatic hyperplasia, but it never increases the risk of cancer. It does not increase the risk of cancer. For the growth of this prostate, what is the stimulus? It's not the testosterone, it's the dihydrotestosterone. Testosterone is converted into dihydrotestosterone. This dihydrotestosterone gives the stimulus for the prostate to grow. Now, how to decrease the dihydrotestosterone levels? By inhibiting this enzyme called as 5-alpha reductase. By inhibiting 5-alpha reductase, you can decrease the DHT levels, and the drugs are finasteride and dutasteride. Now, after this, let's discuss about atrophy, sir. Atrophy क्या है? Sir, what exactly is this atrophy? Sir, can you tell me what exactly is this atrophy? Atrophy is decrease in the size. Okay, increase in the size is hypertrophy. Okay, increase in the size is called as hypertrophy. Decrease in the size of an organ is called as atrophy. Why there is decrease in the size of an organ? Why organ size is getting decreased? Because in that organ, both the number of cells and the size of the cells are decreasing, as well as the number of the cells are also decreasing. Okay, right? So, decrease in the size of an organ or tissue. The size of a tissue is getting decreased. Okay, so both the decrease in the size of the cells as well as number of the cells. Why, sir? What is the mechanism? Hypertrophy is because of increase in protein synthesis. Hyperplasia is because of the mitosis, more number of divisions. And atrophy, do you know, because this is because the size, the tissue size is decreasing, because now in these cells, a pathway will occur, sir, which is called as ubiquitin proteasome degradation pathway. Okay, ubiquitin proteasome degradation pathway. It's happening. It's going to destroy the cellular components, sir. The unwanted cellular components, the proteins, everything is going to be destroyed. So the cell number and cell size decreases. So the organ will undergo atrophy. So as a student, what you should know is, sir, atrophy is due to decrease in both number as well as the size of the cells. Why the cell number and why the cell size is decreasing? In those cells, which pathway is activated? Ubiquitin proteasome degradation pathway. That's activated, sir. Okay. Now, what are the examples? Examples of atrophy. Examples of atrophy are disuse atrophy or wasting atrophy. Okay, wasting atrophy, for example, if you don't use the muscles, maybe in lower motor neuron lesions. Okay, in lower motor neuron lesions, that's for example simple. Let's put it this way. Not the lower motor neuron lesion. I will give you the example in another place. Sir, you are not using a muscle. Everything is okay, but you are not using a muscle. For example, you had an accident. A person is having an accident, and during that accident, there is a fracture. The patient is having fractures. Now he is totally bedridden. Okay. Now he is totally bedridden for 6 months, for example. So he is not using his muscles. He is not using his back muscles. He is not using his thigh muscles. So what these muscles will undergo? As you are not using them, their size will decrease. So wasting, the muscles are getting wasted away. Okay, the muscles are getting wasted away. So that is one example of atrophy. The wasting or disuse atrophy. You are not using it, you are not using them, so their size is getting decreased. Next, malnutrition atrophy. You are not giving a proper nutrition to the cells. If you are not giving proper nutrition to the cells, more catabolism inside the cells. The cells will start to become small in size. Okay, so that is malnutrition atrophy. No nutrition, the cell size will decrease. Okay, tissue size will decrease. Next, ischemic atrophy, sir. So what exactly is this ischemic atrophy? See, ischemic atrophy means, you have decreased the blood supply to the tissue. Okay, so you have decreased the blood supply to that tissue. When you decrease the blood supply to the tissue, ischemia, so automatically the tissue size decreases. Pardon me. Pardon. Got little cold. So, wasting atrophy or disuse atrophy, malnutrition atrophy, no proper nutrition, atrophy will occur, and ischemic atrophy. So, what exactly is ischemic atrophy? Ischemic atrophy means you have blocked the blood vessel, there is a thrombus occlusion in the blood vessels, so there is a decrease in blood flow decreases, atrophy will occur. Okay, next, denervation atrophy. So, what is denervation atrophy? Denervation atrophy means, can you anyone tell me what is denervation atrophy? Anyone in the chat section, can you tell me what is denervation atrophy? Travel expert, can you tell me what is denervation atrophy? Denervation atrophy means, let me tell you, okay, denervation atrophy means all your muscles, okay, all your muscles, they are innervated by the neurons, okay, especially the alpha motor neurons, the lower motor neurons called as alpha motor neurons, they will come to your muscles and they are the ones which are causing the contraction of your muscles. Because of some reason, like in polio, the alpha motor neurons are damaged, the lower motor neurons are damaged. When the lower motor neurons are damaged, now denervation. So, to these muscles, the nerve innervation is gone. Okay, lower motor neuron lesions. So, now tell me, can you use this muscle? No, you cannot use this muscle. Okay, so the lower motor neurons which are coming to this muscle, they will actually cause the contraction. Now, what you should know is this lower motor neurons which are coming, the lower motor neurons or the alpha motor neurons which are coming, they will give the trophic nutrition. They will give the trophic nutrition to the muscles. If there is a denervation, the trophic effect is lost. Okay, so that will cause atrophy of the muscles. So that is called as a denervation atrophy. So tell me, what exactly is atrophy? Atrophy is decrease in the size of the tissue. Why there is decrease in the size of the tissue? Because both decrease in the size of the cells as well as the number of the cells. What is the pathway that is running in them? Ubiquitin degradation, ubiquitin proteasome degradation pathway. What are the examples? Diffuse atrophy, malnutrition atrophy, ischemic atrophy, and denervation atrophy. Completed. This is me in that YouTube video. I have explained, sir, atrophy. Listen. When a patient is having, see, देखो, endometrial hyperplasia, now she is going to have type 1 endometrial cancer. I have said you, endometrial hyperplasia can lead to endometrial carcinoma. They increases the risk. Which type of cancer? See, endometrial hyperplasia, this is very important for the exams. If there is endometrial hyperplasia in a postmenopausal female, it will cause type 1 endometrial cancer. But sometimes, do you know what happens? Endometrial atrophy. Endometrium is undergoing atrophy, sir. Okay, endometrial atrophy. So this endometrial atrophy, right now our topic atrophy. So if there is endometrial atrophy, it will cause type 2 endometrial carcinoma. Type 2 endometrial carcinoma. So type 2 endometrial carcinoma is associated with atrophy. Type 1 endometrial carcinoma is associated with endometrial hyperplasia. That's also something important, especially for your exams. Okay. I have done this video. I have already recorded this video in the YouTube. You can watch the lecture if you want. You can go through the endometrial cancer video. Now, after this, let's talk about the other cellular adaptation. The next cellular adaptation, sir, which is called as metaplasia. Okay, metaplasia. So, what is metaplasia and what you should know for your exam? Okay, so metaplasia means change in one cell type. Okay, one cell type is going to change into other cell type, totally different cell type. So, change of one cell type into other type is called as, okay, metaplasia. Why it is changing? Because of the stress. Okay, because of the stress. What is the mechanism underlying here? Again, for hypertrophy, increase protein synthesis. For hyperplasia, it is the mitosis. For atrophy, it is the ubiquitin proteasome degradation pathway. And for metaplasia, say, there is something called as stem cell reprogramming. So, stem cell reprogramming will occur. So, because of this, yes, because of this stem cell reprogramming, one cell type will change into the other cell type. The stem cells program, the program of the stem cells is changed. Now they are forming different cells. Now they are forming different types of cells. I will give you examples. Examples are most important. The questions which were asked in the FMG exam and NEET PG exam and even in the board exams, usmle exams, the question which will come is, which vitamin deficiency can lead to metaplasia? Which vitamin deficiency? Vitamin A deficiency. Okay, vitamin A deficiency can lead to metaplasia. Why? Because for epithelial differentiation, vitamin A is very important, sir, very important. But if there is vitamin A deficiency, that will lead to metaplasia. Examples. This is from here. These are the important points which you should know. There is something called as Barrett's esophagus. Sir, what is Barrett's esophagus? Normally, let me draw here. Imagine this is your esophagus and here is your stomach. Okay, this is your stomach. Now, when acid is refluxing, okay, yeah, that's why we'll give retinoic acid. Yes, travel expect, you are true. Retinoic acid, vitamin A. Okay. Later I will explain about the retinoic acid, vitamin A. But for now, just listen here. Sir, acid, when it was supposed to be present where? Acid was supposed to be present in the stomach. Now, if this acid, if it is regurgitating into the esophagus, if the acid is coming back into the esophagus, is that good? Is that good? Definitely not good, sir. So, normally esophagus is lined by which epithelium? Sir, esophagus is lined by stratified squamous epithelium, sir. Esophagus, it is lined by the stratified squamous epithelium. Now, because of this insult, because of this stress, continuous stress, acid is coming. Do you know what happens now? Now, in the esophagus, the epithelium is changed into columnar type of epithelium. The squamous epithelium is replaced by the columnar type of epithelium because of the stress, especially in the lower one third of the esophagus. So, yes, in the lower one third of the esophagus, squamous epithelium is gone, replaced by columnar epithelium. So, along with this columnar epithelium, important point, even you can see goblet cells. Okay, goblet cells. Even along with this columnar epithelium, goblet cells are seen. This is the MCQ. Okay, which cells are seen? Goblet cells. Goblet cells are seen. Pen is misbehaving. Okay, so goblet cells are seen. Why goblet cells are seen, sir? Why goblet cells have occurred, like, why they came into the esophagus? Do you have any idea why goblet cells are coming into the esophagus? Normally, in the esophagus, there are no goblet cells. Goblet cells are not seen in the esophagus. Okay, now, why the goblet cells are coming? The goblet cells are going to now produce the mucus. Okay, now they are going to produce the mucus in the esophagus. Why mucus? Acid is regurgitating back? No. There is gastroesophageal reflux disease, GERD. So, the patient is suffering with what? GERD, gastroesophageal reflux disease. The acid is getting refluxed back into the esophagus. Okay. So, what happened? The squamous epithelium, the squamous epithelium is replaced by columnar type of epithelium, intestinal type of columnar epithelium along with the goblet cells. The goblet cells are now going to produce the mucin there, mucus over there. Okay. So, this is one example, Barrett's esophagus. Now, just tell me, seen in which condition? Barrett's esophagus seen in GERD, gastroesophageal reflux disease. And what you will see over there, I have explained you, sir, what you are going to see in Barrett's esophagus, there is columnar metaplasia. Okay, there is columnar metaplasia. Which type of columnar metaplasia? Intestinal type of columnar metaplasia. Why I am using the word intestinal type of columnar metaplasia? Why? Because goblet cells are seen in the intestines, not in the stomach, not in the esophagus. Now you are having the goblet cells also. So it is called as intestinal type of columnar metaplasia, and that's the MCQ. Okay, that's the MCQ. Next, what else are the examples of metaplasia? That's the myositis ossificans. Myositis ossificans means what? For example, whenever you are having trauma, sometimes when you are having trauma, now in the muscles, after some days, now you will feel hard lump or mass, which is nothing but the bone, sir. Now a bone formation is happening in the muscles. Bony tissue is growing inside the muscles after trauma, which means one type of tissue, the mesenchymal tissue, one type of the muscle tissue is changing into bone type material. So this is called as a myositis. So myositis means inflammation within the muscles because of the trauma. At the end, bone formation, ossificans, bone-like growth is happening. So myositis ossificans is an example of metaplasia. And smoker's lung. So normally in your lungs, columnar epithelium is there, ciliated columnar epithelium is there. This is the most common type of metaplasia. This is MCQ. It's the most common type of metaplasia, sir. What is that? Squamous metaplasia. Do you know what is happening now? Normally in the lungs, ciliated columnar epithelium is there. Okay, ciliated columnar epithelium is there in the lungs. Do you know what is happening now? See, this ciliated columnar epithelium, when the person is smoking, continuously smoking, now because of the smoke, the ciliated columnar epithelium is converted into squamous epithelium. Okay, so this is an example. Ciliated columnar epithelium converted into squamous epithelium. So this is called as squamous metaplasia. Okay, squamous metaplasia. One more and travel expert. See, normally inside the lungs, what do you have? You have ciliated columnar epithelium. When the person is smoking continuously, there is a stressor. So the ciliated columnar epithelium, okay, is going to be converted into squamous epithelium. So end result is what? The squamous epithelium. It's getting changed into squamous epithelium. So it is called as squamous metaplasia. And one more example. So smold or Zuska's disease. Okay, smold or Zuska disease in smokers, in smoking females. Okay, in smoking females, actually this type of metaplasia is seen in the breast, sir. Okay, so squamous metaplasia of lactiferous ducts. Smold means SMOLD. SMOLD means smold means squamous metaplasia. See, metaplasia is happening. They will ask you, smold is an example of which type of cellular adaptation? Smold is an example of metaplasia. Smold means squamous metaplasia of lactiferous ducts. Lactiferous ducts in the breast tissue, they will undergo metaplasia. Okay, so this is also one more example. So what we have seen, what are the examples of metaplasia we have seen? Barrett's esophagus, okay, seen in the GERD, myositis ossificans, smoker's lung, and Zuska's disease. All these are the examples of metaplasia. And in metaplasia, what is that keyword? So in metaplasia, this is because of stem cell reprogramming, where one cell type is getting changed into other cell types. Okay. Next. Sir, lastly, dysplasia. Let me ask you something about the dysplasia. Okay. So dysplasia, is it a cellular adaptation? Sir, hypertrophy is a cellular adaptation, hyperplasia is a cellular adaptation, atrophy is a cellular adaptation, metaplasia is a cellular adaptation, but dysplasia is not a cellular adaptation, sir. Dysplasia is not a cellular adaptation. And remember one more thing, all the cellular adaptations, whatever I have discussed, all the cellular adaptations are reversible. Okay, if you take out the stress, if you remove the stress, atrophy, metaplasia, hypertrophy, hyperplasia, everything will be reversed. Everything is reversed. So now let me write here, all cellular adaptations are reversible, no doubt. Let's take a note somewhere. Very important note. All cellular adaptations are reversible. Okay, all cellular adaptations, they are reversible, sir. So the question which was asked in the exam is metaplasia or the Barrett's esophagus. If the patient is Barrett's esophagus, is it reversible? Absolutely, absolutely reversible. Okay, so metaplasia is reversible, sir. Next. So what is dysplasia? Dysplasia is not a cellular adaptation. Now it's a total disorganized growth of the cells. Now there is so much stress, cells are trying to adapt. There is one stage, they gave up, and the totally they are growing in abnormal fashion, sir. Now they are growing in abnormal fashion. Now you can't even identify the cell, disorganized growth of the cells. You can't even identify what type of cell this is. Okay, so dysplasia is not a cellular adaptation. It's not a cellular adaptation. So what exactly is happening in dysplasia? Keywords: disorganized growth of the cells, loss of differentiation. You cannot identify whether it's a cardiac myocyte, whether it's a hepatocyte, whether it's a renal tubule. You cannot identify it, sir. Disorganized growth. Okay, and is it reversible? All cellular adaptations are reversible, but this is irreversible. Once dysplasia is there, it is not reversible, sir. It is irreversible. It is irreversible, and it is a precancerous stage, almost going into the cancer. Almost the cells are going into cancer, sir. Okay, so with this, our topic cellular adaptations is also completed. Okay, I have given you important examples. Examples are the key. Examples are the important things. Okay, so benign prostatic hyperplasia, endometrial hyperplasia, type of endometrial cancer is a type 1 or type 2. Okay, and what are the transcription factors, GATA4, NFAT and MEF2. So everything, whatever I have written over here is an MCQ in the previous year questions. Now after this, let's discuss about topic which is called as a cellular intracellular accumulations. Okay, in certain conditions, in certain pathological conditions, certain substances will start to accumulate inside your cells. For example, like iron accumulation, copper accumulation, glycogen accumulation, calcium accumulation. So in certain pathological conditions, in different pathological conditions, different substances will start to accumulate inside your cells. So that's our topic, sir, intracellular accumulation. Okay, so here first I am going to discuss about the pigment. Normal, sir, normal healthy cells also. Which pigment is there? In our skin, in the basal most layer. So for example, you can see here, sir, here see, are you able to see this black color? This is black color which is present in the deep layers of the skin, not on the superficial layer, in the deep layer of the skin, sir. That's a stratum basal layer of the skin. Are you able to look? Then the stratum basal, you can see the melanin pigment. Melanin pigment, that's the one which gives the color to our skin. Okay, so melanin is a pigment. Yes, it will accumulate in our cells. Okay, it's going to accumulate in our cells. So melanin, where it is there? It is there in the skin. Okay, but not only there, in central nervous system also. Look here. So what is this area? Can you tell me? So this black color area which I have highlighted over there, that's called as a substantia nigra. Okay, substantia nigra. Sir, this is healthy midbrain. Okay, this midbrain, this is actually midbrain, sir. This is a healthy midbrain. So in this midbrain, see, dekho, what happened to the substantia nigra, sir? The substantia nigra became pale substantia nigra. Can you tell me what is this condition? Can anyone tell me what is this condition? Travel expert, fun mode, can you guys tell me what is this condition? Can you tell me what is this condition? This condition is actually Parkinson's. Yes, fun mode, you are true. This is Parkinson's. So in Parkinsonism, actually what happens is the dopaminergic neurons, okay, from here, right, the dopaminergic neurons are damaged. The dopaminergic neurons in the substantia nigra, they are damaged, sir. When the dopaminergic neurons are damaged, look, dopamine is the raw material for melanin. Dopamine is the raw material for melanin. Normally, here this black color is because of the melanin, sir. Because of the melanin, the black color is there. Now, in Parkinsonism, what happened? The dopaminergic neurons are gone. Dopamine is not there. When dopamine is not there, melanin synthesis cannot happen, sir. When melanin synthesis is not there, see, it became pale. Okay, so pale substantia nigra is seen in Parkinsonism due to loss of dopaminergic neurons. Dopamine is not there. When dopamine is not there, melanin is not produced. Okay, so that's the point which I want you to know. So melanin, it's a pigment. It is there in our skin, stratum basal layer of our skin, as well as substantia nigra. Questions that will come in your exam is direct pathological questions, sir, pathology related questions. What are the stains? What is the stain for this pigment, sir? The stain for melanin is Mason-Fontana, right? Mason-Fontana is the stain. Small stain, Mason-Fontana, small stain, and immunohistochemical stain is there, which is called as a HMB45. This is the MCQ, which was asked in the exam. So HMB45 is the immunohistochemical stain. It's also a type of stain. Okay, immunohistochemistry. In the immunohistochemistry, to stain, to look at the melanin, this is the stain used. HMB45, Mason-Fontana, small stain, and what is this? EHC, enzyme histochemistry. In enzyme histochemistry, the stain which is used is called as a dopa oxidase. So tell me, to stain melanin, to look at melanin under the microscope, what are the 4 stains which are used? There are 4 different types of stains which you can use. One is small stain, Mason-Fontana, HMB45, and dopa oxidase. Dopa oxidase. These are the stains which are used. Next. Now let's talk about the pathological conditions. There is a pathological condition in which the iron will start to accumulate inside our cells. Iron is starting to accumulate inside our tissues. What is that condition? Hemosiderosis or hemochromatosis. Hemochromatosis, sir. Now, hemosiderin is getting accumulated. Okay, hemosiderin means what? Iron accumulation inside the tissues. Seen in which condition? Sir, seen in hemochromatosis. In this condition, hemochromatosis, you can see iron accumulation inside our cells. So, how to identify the iron? Look at here. Sir, this is the tissue. Actually, what is this tissue? Can you identify? Sir, this tissue is nothing but your renal tubules. These are renal tubules. So, renal tubules, sir. So, inside the renal tubules, are you able to appreciate this blue like dots? So, those blue color, this is nothing but iron. Okay, inside the renal tubules, iron is getting accumulated. Okay, actually this is seen in a condition called as paroxysmal nocturnal hemoglobinuria, where the hemoglobin is going to leak out in the urine. Now in this particular condition, now iron will start to deposit inside the kidneys. Okay, iron will start to deposit inside the kidneys, renal tubules. Okay, now this is called as a blue kidney. Okay, this is called as a blue kidney. Now question is, how to look at the iron? What is the stain used? The stain used is pearl stain or Prussian blue. Iron will look in blue color. Iron is going to look in blue color. Okay, so what is the stain for iron? Pearl stain or Prussian blue, already asked MCQ in the exams. Next, copper accumulation. If copper is getting accumulated inside your tissues, in which condition, which disease, sir? Wilson disease. There is a disease called as a Wilson disease. In this disease, ATP7B gene is mutated, question which was previously tested. So, ATP7 gene mutation, ATP7B gene mutation leading to the Wilson disease. Now, in this disease, what happens? Now, copper will start to accumulate inside our body. This is the image based question which was asked. Are you able to see? Sir, this is the copper deposition, okay, in the eyes. Copper deposition in the eyes, sir. Do you know what is this called as? What is this? So, these are the, anyone? KF rings, Kaiser-Fleischer rings. Okay, so KF rings, so we will call it as KF rings. Okay, so KF rings are seen in which condition? Wilson disease. Due to what? Copper deposition. Why Wilson disease? ATP7B gene mutation. Okay, ATP7B gene mutation. Now here, I want to test your knowledge. Fun mode and travel expert, you just try to answer me. Other students, if you know, you can answer me. Copper excess copper in the body will cause Wilson disease. Copper deficiency, I have explained. Copper deficiency will cause which disease? Copper deficiency. Okay, I haven't explained for the you guys. I have explained for the other batches. Copper deficiency is going to cause which disease? Anyone? Fun mode? Travel expert? In the body, copper deficiency. Any idea? Copper deficiency. Not Wilson, not Wilson. Copper excess will cause the Wilson disease. Excessive amount of copper in the body will cause the Wilson disease. Right now I am talking about copper deficiency. Copper deficiency, remember, especially important for your exams, Indian exams, that is Menkes disease. Menkes. Okay, so Menkes-Kinkey disease. Menkes-Kinkey. So Menkes-Kinkey disease is due to deficiency of the copper. Now tell me, sir, what are the stains for the copper? How to identify the copper, sir? So the stains which are used are rubianic acid. Okay, rubianic acid and rhodanin, not rhodamin, rhodanin stain. Rubianic acid and rhodanin is the stain for the copper. Okay, these are the two stains which are important. Rubianic acid and rhodanin. Next after this, so what is ceruloplasmin? Sir, ceruloplasmin, what is ceruloplasmin? It's a plasma protein which will bind with the copper. So copper binding protein is called as a ceruloplasmin. Now this is also just I am trying to integrate here. So ceruloplasmin, if you want to stain the ceruloplasmin, not the copper, if you want to stain the ceruloplasmin, then the stain which is used is called as arsine stain. Okay, arsine stain is the stain for ceruloplasmin. And there is this one more pigment which is called as a homogenesic acid. Okay, it's an acid, it's homogenesic acid. Now even we are talking about the intracellular accumulations, right? Now there is a condition called as alkaptonuria. Okay, in alkaptonuria, which substance will start to deposit inside our tissues, which substance will accumulate inside our tissues? It's called as a homogenesic acid. Okay, now when homogenic acid is getting accumulated, now there will be blackish color discoloration. Now you can clearly see here in the ears, this is the image based question that will give you this light black to bluish color discoloration that is seen. This condition is called as achronosis. Okay, so achronosis is due to accumulation of which substance? Iron, copper, melanin, hemosiderin? No, homogenic acid accumulation will cause achronosis seen in alkaptonuria. Okay. Next, let's discuss about one more pigment, sir. One more pigment accumulation inside our tissues. See, this pigment very much important, especially for the Indian exams and board exams. The pigment name is called as a lipofuscin or lipochrome. When we are getting older and older, okay, when we are getting older and older, inside our cells, this pigment will start to deposit. As we are getting older and older, our cells are going to have more and more free radical damage. In our cells, more and more free radical damage will occur. Now, due to the free radical damage, these free radicals, they will cause, do you know what these free radicals will do? These free radicals will cause lipid peroxidation inside our cells, the lipid peroxidation. When the lipids are getting, when lipid peroxidation occurs, then these pigments are going to be produced. Due to lipid peroxidation, this lipochrome is going to be produced. Okay, so one by one. Sir, what is this lipochrome or lipofuscin? This is a wear and tear pigment. It's a wear and tear pigment, means with the time, with usage, with time, with repeated damages, with time, this tissue, pigment is going to start accumulating inside our cells. Now, where it is seen, sir? It is in the brown atrophy of the heart. Okay, this old patient, 80-year-old patient, now he is dead. 80-year-old patient, he is dead. Now, when you look at the tissue, when you look at the biopsy, you can see this brownish color depositions, this brown color pigment deposition around the nucleus. This brown color pigment is nothing but the lipochrome or lipofuscin. It's a brown color pigment. It's a brown color pigment. Okay. Next. Now, why this lipochrome or lipofuscin? I have explained you, it is because of the free radical injury causing lipid peroxidation. When the lipids are undergoing peroxidation, that will produce lipochrome or lipofuscin. Now, where it is going to be accumulated? It is going to accumulate around the nucleus, perinuclear brown pigment deposition. If this is a keyword, wherever you see this word, perinuclear brown pigment is seen. That is nothing but lipochrome or lipofuscin due to free radical damage. Now, what is the stain? So, what is the stain used for this lipochrome or lipofuscin? We can very clearly see here this brown pigment around the nucleus. Even here, this is the nucleus. This is electron microscopic image where you can see the lipochrome. Okay, lipochrome, it's seen around the nucleus. Now, what are the stains, sir? The stains for this lipochrome or lipofuscin is oil red O. Oil red O is the stain, and Zn stain, Zn-Nielsen stain. Okay, Zn stain. You know it, Zn stain is used for the mycobacterium also. Okay, so oil red O and Zn-Nielsen stain are the stains used for the lipochrome or lipofuscin. Next, let's talk about the lipids. Pigment accumulation completed, iron accumulation, copper accumulation, pigment accumulation like lipochrome completed, sir. Now, let's see lipids. There are certain conditions where even lipids, these lipids, extra amounts of fats will start to accumulate inside your cell. Do you know any such condition? Liver, sir, fatty liver. Okay, so fatty liver is the most common. Okay, so lipids are going to be accumulated, and the most common organ too for the lipid accumulation is the fatty liver. It's a liver causing fatty liver. If the more and more fats will start to accumulate inside the hepatocytes, that will cause the steatosis or fatty liver. Now, one more condition you can very clearly see here. So, can you tell me what is this organ? Can you tell me what is this organ? That's the gallbladder, sir. That is the gallbladder. Okay, gallbladder. Now, even in the gallbladder, you can see these are all the cholesterol deposits. All these are the cholesterol deposits. Now, gallbladder, it's looking like a strawberry. Okay, this is called as a strawberry gallbladder. So, in strawberry gallbladder, what is happening? It's the cholesterol that's getting deposited. Okay, so this condition is called as cholesterolosis. Okay, cholesterolosis or strawberry gallbladder. What is happening? It's a lipid accumulation inside the cells. Okay, lipid accumulation. Now, how to identify the lipids, sir? Okay, for lipids, see, whenever you look at the cell, see, all these vacuoles are there, right? These are nothing but the spaces where previously lipid is there. Previously here lipid is there, right now the lipid is washed away. Now all these are the spaces where lipids are there. Okay. Now how to identify the lipids, sir? What is the stain for the lipids? If you want to look at the lipids, what is the stain used? The stain used is oil red O. Okay. So oil red O. Now where we have, just look at here, the same oil red O we have seen here. Oil red O is used for lipofusion. Also the oil red O, mainly it is used for the lipid set. Lipids important. Not only oil red O, Sudan black B, Sudan 4 and osmium tetroxide. All these are the stains, MCQs, previous year MCQs, oil red O, Sudan black B, Sudan 4, osmium tetroxide. These are the stains used for lipids, okay, are the fats. Now look here, there you go, here also clearly written. See, when you use oil red O, all this red color, okay, red color, like here what you can see, these are nothing but the lipids. These are all the lipids. Lipids are going to come in red color. Okay, the appearance of lipids in light microscopy, left one, this one is oil red O and right one is Sudan black 4. Okay, see, in Sudan black stains, the lipids are going to take which color? The lipids are going to take the black color. Okay, lipids will be having black color, sir. Okay, so what is the stain? They can give you image based questions and they can ask you, the stain is oil red O and this is Sudan black 4. Okay, so lipids also completed. Look at this, this is a strawberry gallbladder or cholesterolosis where excessive lipids are getting deposited inside the tissues. When you are suffering with hypercholesterolemia, lipids will start to deposit. Okay, next, and we are at the end, glycogen, sir. Glycogen is getting deposited inside the tissues. Okay, we have seen copper deposition, iron deposition, fat deposition, brown pigment deposition, okay, homogenesic acid deposition. Okay, but there are certain diseases where now glycogen will start to deposit inside the tissues. Do you know any such thing? Diabetes mellitus, sir. In diabetes mellitus, okay, look, in diabetes mellitus, what happens? More and more glucose is getting filtered into the nephrons. More and more glucose. Now this glucose will be reabsorbed in the proximal convoluted tubules. Now what is happening in diabetes mellitus? More and more glucose is getting filtered into the nephrons. Now this glucose will be reabsorbed by the proximal convoluted tubular epithelial cells. Now in the PCT, the glucose is stored, sir. Now in the PCT epithelial cells are storing the glucose, converting the glucose into glycogen, and now they are storing the glycogen. Okay, so now this PCT cells, now these epithelial cells which are storing this glycogen, they are called as Armani-Epstein cells. Okay, MCQ, Armani-Epstein cells are seen in diabetes mellitus, where that's like diabetic nephropathy, I should say, diabetic nephropathy. More and more glucose is filtered, that glucose is stored in the PCT in the form of glycogen. Those cells are called as Armani-Epstein cells. You can very clearly see here. See, these, look here. Let me show you one thing. See, often referred as Armani-Epstein change or Armani-Epstein cells. So what exactly are these Armani-Epstein cells? These Armani-Epstein cells, they are nothing but, okay, these Armani-Epstein cells, they are nothing but the cells which are storing the glycogen inside them. So what is this? Okay, these are all the Armani-Epstein cells, they are storing the glycogen within them. Okay, next, what I want you to know is, sir, what is the stain for this glycogen? How to stain the glycogen, sir? So the stain for the glycogen is PAS stain. Okay, periodic acid shift stain. Okay, periodic acid shift stain. So PAS stain is the stain for glycogen. Periodic acid shift stain is the stain for glycogen. Okay, and one important point about the glycogen is, sir, glycogen, yes, it will take the PAS stain, it will come pink in the stain. Okay, wherever there is glycogen, where if you put PAS stain, the glycogen will be coming in pink color. It will come in pink color, sir. But this glycogen, one thing you should know for understanding the other concept later, sir, this glycogen, it is a diastase sensitive. So diastase is an enzyme. It's an enzyme. When you put diastase over there, the glycogen will be dissolved. Glycogen will be going out of that area. Okay. So glycogen is PAS positive, but diastase sensitive. Okay, glycogen. So with this, glycogen is also completed. So So tell me, in which condition glycogen will start to accumulate inside the cell? One thing I have explained you, diabetes mellitus, that's the Armani-Epstein cells in the proximal convoluted tubule. And not only that, here there are glycogen storage disorders, right? In biochemistry you would have studied glycogen storage disorders. The glycogen is getting accumulated inside the cell. Now in all those conditions, glycogen is accumulated inside the cell. How you can know whether it's glycogen or not? Put pastane. If the cells are taking pastane, which means inside them there is glycogen vacuoles are there. Okay, so with this intracellular accumulations is also completed. Okay, so the day 2 class is completed. Now we will continue with the third class. Okay, in third class we will do some more important topics in the cell injury. Some few topics are there like calcification and phagocytosis. The phagocytosis and the calcification topics will be done in the next subsequent video, and the next class we will start the other chapter also, inflammation also. We will start with the inflammation. The main chapter will be inflammation, but before that chapter I will also be discussing a small topic of phagocytosis and not phagocytosis, sorry, the small topic autophagy as well as the calcifications will be also discussed in the next session. Okay guys, is that helpful? Shall we close the topic for today? So the PDF will be shared with you, okay? The PDF will be shared with you in the Telegram group. Complete topics. If today this topic is completed today itself, complete before going to the bed, just go through it, memorize them, so that we can complete the entire thing in 30 days. Okay, in 30 classes we have to complete the entire pathology, all that what is needed for your exam. If you know this, yes, you can clear your exam. That's it. It should be something like that. Okay guys, see you in the next class. Good night.